Good afternoon, everyone, and welcome to the COVID-19 2.0 Health Literacy Echo for medical providers. Brought to you by Health Confianza, a collaboration between the UT Health San Antonio and the San Antonio Metropolitan Health District. Thank you very much for making this time one of your priorities today and join us in our session. I would like to mention that we're recording this session today so we can share it later. But please note that anything listed in the chat will be seen in the recording. My name is Raquel Romero. I hope you and your family are doing well. I'm a physician by training, and I'm going to be the facilitator for the session today. We have a lot of information to cover, but before we begin, I would like to ask our UT Echo IT to provide some direction for us. Thank you very much, Carly.
Hi, please stay muted unless you're speaking. You can use *6 on your phone if called in, or the microphone icon on the bottom left of your screen if you've joined on a computer. You can also communicate with the chat feature. If you are having issues with your connection, you can privately chat with me, UT Echo IT. Thank you.
Thank you very much for these instructions, Carly. Additionally, yes, please remember that if you have some issues with the connection, you can add your comments in the chat box, or you can send a private message to the UT Echo IT also. I would like to encourage you to add your comments, perspective, and questions in the chat box during the session today. We will try to follow up them. You can also reach out to us after this session by email, and we promote interaction in our sessions, and we would like to see everyone's faces. If you are able and if you're comfortable, I would like to invite you to join us in this session, especially in the video, in the discussion part of this portion. And please remember that no personal health information is allowed within discussing cases and scenarios. I would like to mention that once you register for one session, you automatically are registered for the complete series. And I would like to continue with the introductions, and there is a large group. So would you please help us with our attendance records and add in the chat box your name, your title, your contact information, your email, and the organization, institution that you represent. Health Confianza is a county-wide collaboration to improve access and the uses of the COVID-19 health information and service in Bejar County. With that, and before we started, I would like to use this space to introduce our COVID-19 Health Literacy Echo team. And I would like to start with Dr. Berggren. Good afternoon, Dr. Berggren.
Hi, welcome everyone. Can you hear me?
Yes, perfect.
Delighted to see a wonderful turnout for today's session, which will be delivered by Dr. Jason Bowling. I am a professor of medicine and an infectious disease specialist. I direct the Center for Medical Humanities and Ethics, which is a proud home for Health Confianza. Welcome again.
Thank you very much. Dr. Berggren is also the specialist and moderator for our session today. We have Dr. Bowling, the doctor's presenter.
Hi, I'm Jason Bowling. I'm an associate professor in the Division of Infectious Diseases, and I'm happy to be here today. Thank you.
Thank you very much. And we have Dr. Case, panelist for our session today.
Hi, I'm Kathleen Case, and I'm an assistant professor at the Reach Center, and I have training in health communication, and welcome everyone today.
Thank you very much. And also we have Dr. Castro Peña, panelist.
Yes, hello, how are you? My name is Alexandra Castro Peña. I'm internal medicine and infectious disease physician. I work here at Gonzaga Medical Group. That is outpatient center mainly for really underserved area here in San Antonio.
Thank you very much. And also we have Dr. Lindsay Groff.
I just called into the OR. Dr.
Hi, everyone. My name is Lindsay Groff. I'm one of the infectious diseases pharmacists at University Health System here in San Antonio.
Thank you very much. And also I want to thank the ECHO team to make those sessions possible. ECHO stands for Extension for Community Healthcare Outcomes. The goal of this model is to bring knowledge when it's needed, where it's needed, and to build community capacity for delivering best practice. The core component of these sessions are didactics, case discussion, and a conversation. The case discussion is an important component of the ECHO model. We invite you to submit clinical or non-clinical cases to be presented in our sessions. And ECHO will share the instructions in the chat box. These sessions are possible because of you, because your interest, and because your participation and your feedback is so important. Toward the end of the session, we want to share a link to that you can provide a feedback for us. These sessions provide credits, the CME, the CNE, and it is continuing medical education. To obtain those credits, the activity code for today is 100-91773. As a part of our agenda, we have next the tactics and then this case discussion. Finally, I would like to mention the ECHO is all teach or learn environment, so we encourage you to share your experience, questions, and insights in this conversation. With no more from my end, I would like to start with Dr. Bowling for the didactics. Dr. Bowling, this is your space. Thank you so much. Dr. Bowling, you are muted.
Thank you. All right, so I'm sharing my, all right, there we go. All right, fantastic. Thank you. So I appreciate the opportunity to talk with you all today about outpatient management of COVID-19. I think this is really timely. We've seen a lot of shift from treatment. We're going to focus on patients that have COVID-19 but aren't sick enough to be in the hospital, aren't requiring oxygen. Is really going to be the focus of today's session. And that's really where we're seeing most of our patients at this point. About 80% is the estimate. Next slide. So here we have our front matter. Don't forget to get your CME. There's the instructions here. Here's the disclosures. See, I'm a co-investigator on the ACT study, and I have a prior role with Eli Lilly. Here's our learning objectives today. So we're going to talk about the name and compare the 4 targeted COVID-19 therapies, where we're at with COVID-19 therapies for our outpatients, pros and cons of each of those. And then we'll also talk about online resources. So we all know that you can't know everything, but it's important to know where to find things, right? So knowing about where resources are is really important. Next slide. So this is just on for some context where we're at with COVID-19. I think one of the important things that we need to do as we transition from COVID-19 pandemic to learning to live with COVID is similar to how we work with influenza, which is really knowing how much COVID-19 is circulating in our community, so you can know about when to have a higher pretest probability for COVID-19 in your patient. Fortunately, things seem to be declining again with COVID-19. We all know this has been a roller coaster, but we're starting to see declining cases, which is good. Bexar County is still high activity, but improving. You can see that this map of the United States, the majority of the United States right now is in medium activity. So it's coming back down from our most recent prolonged surge with Omicron variant. So it's encouraging to see that it's coming down, but we're still seeing a lot of COVID. Next slide. The other important thing, I just want to put this on here, is that we know how much activity is important, but there's also different variants, right? We know that SARS-CoV-2, the virus that causes COVID-19, mutates over time. And as it mutates, it spins out these different variants. This particularly impacts our monoclonal antibody therapies. It's been really hard to keep monoclonal antibodies that are effective against circulating variants. They start to lose efficacy with these mutations. And so there's really more of a shift now to some of the other medicines that we're going to talk about. So I think monoclonal antibodies will be less and less used just because it's so challenging to keep up with the different variant strains. And so I think that impacts the therapy discussion that we're going to have as well. Next slide. Prevention, we're going to briefly talk about prevention because it's still key. We're going to talk about treatments for most of this session. Next slide. But one of the key things to remember is that vaccines are still our best way to prevent people from getting infected. This is full vaccination with boosters for people that are eligible to get boosters. These are still our best protection against severe disease, hospitalization, and death. Even we know that they're not 100% in preventing symptomatic infections. People can still get infected, but you still want to have that vaccine on board. mRNA vaccines with boosters still have efficacy against these Omicron variants that are circulating currently. You can see data here that's available, 82% protective against going to the ER, 90% protective against hospitalization with these Omicron variants. So it's really important that all of our patients stay up to date on vaccines. These treatments we're going to talk about are for the breakthrough infections, but it doesn't take away the importance of getting the vaccines. Also, as we've all seen in the news, there's a bivalent vaccine that's going to be available soon this fall. Now we're seeing reports that maybe as early as September, but September-October timeframe. That includes the original SARS-CoV-2 strain and components of BA4, BA5. BA5 is 89% of the circulating variants right now. And then also still important for our patients to know about the symptoms of when they should get testing. I think many people now are familiar with that. but that's still going to be important moving forward for people to get tested. I'm concerned that over time, people are going to stop testing as frequently, but it's still important for people to know if they have COVID-19 to reduce their risk of transmission to others and to see if they need to get therapy. Next slide. The other thing for prevention, just to mention, there is a different monoclonal antibody than what we talk about for treatment that is available for our highly immunocompromised patients that aren't expected to respond to vaccine. And this has probably been underutilized for some of our really immunocompromised patients. It's tixagevimab, silgavimab is the name of the combination monoclonal antibody. That's a mouthful. Evusheld is the trade name. It's basically 2 intramuscular injections, and this is for preventing COVID. This is not for treatment of people that have COVID. It lasts for about 6 months, so it's long acting. So the EUA is for highly immunocompromised patients. It is not a substitute for a vaccine. So if a patient can get a vaccine, that's still preferred. That vaccine protection is going to last longer, but it's for those patients that may not respond or can't get the vaccine because of a serious reaction. It does have a couple of warnings. You can have hypersensitivity as you can with any monoclonal. It's an IM injection, so if you have somebody with a bleeding disorder, that's something to keep in mind. And in the initial studies, compared to placebo, there was a slight increase in cardiovascular events, so something to think about if someone has a prior history of cardiac disease. But this is available and something to consider for your highly immunocompromised patients for prevention. Next slide. So we're going to spend most of the time talking about treatment because that's what we're here to talk about. Again, these are outpatients, people that have COVID-19, don't need to be admitted to the hospital, and aren't requiring oxygen. Next slide. So one thing is important is to think about what all patients should receive if they have COVID-19. And that's supportive care. So they need to make sure that they're doing general health maintenance practices, right? Staying hydrated, you can get dehydrated easily with infections, getting sleep. They can use antipyretics or analgesics if it's safe to do so. And then an evaluation of their risk for progressing to more severe disease, because all of these therapies that we're going to talk about, these targeted therapies, are really indicated for people that are at high risk for progression to severe disease. People that don't have those risk factors really don't have much benefit. And there's more and more data coming from trials that are continue to be performed showing that people that aren't at elevated risk really don't have a lot of benefit from these targeted therapies. All patients also need to receive instructions on how to reduce transmission. So they need to be told about isolation and masking, even if they heard it before. We know that recs change over time. And then the warning signs of when they should seek treatment. If they were to get worse, what they should look for if they need to be reevaluated. Next slide. So we're going to talk a lot about COVID-19 specific therapies, and this is the new current kind of landscape for it. So the NIH has a recommended prioritization of these therapies. Before it was kind of open, and now it's more stratified. And so top is nirmatrelvir ritonavir, trade name Paxlevid, which is what everybody calls it. I'll probably start using Paxlevid just because it's easier to say. But nirmatrelvir ritonavir is oral. We'll talk about that. That's the top choice. And that is followed by remdesivir, which we've used in inpatient, but there's good data supporting it for outpatient therapy as well. The challenge here is that it's IV. Those are your top 2 choices. So number 1, nirmatrelvir ritonavir. Number 2, remdesivir. Alternative therapies, the only monoclonal antibody that works against current circulating variants right now is bebtelovimab, and that's moved to alternative therapy status. Molnupiravir is the other alternative therapy, and we'll talk more about that. The reason that nirmatrelvir ritonavir or Paxlevid and remdesivir are the top therapies is because they have high clinical efficacy in phase 3 trials. And so they have the best data supporting them as good agents to use for our patients at risk for progressing to severe disease. Things that you're going to think about: clinical efficacy, how available it is, feasibility of an IV, right? That can be tricky. And so if you try to find a place to give an IV, that might be, depending on where you're at, more difficult to do. Drug-drug interactions is the big issue with Paxlevid. And then the prevalence of variants of concern. This is especially the case for the monoclonals. And again, as I mentioned earlier, one of the reasons that we'll probably see less use of monoclonal antibodies for treatment of patients as things move along. Next slide. So let's start off with Paxlevid. There's been a lot of this in the news, especially since President Biden and Dr. Fauci both received this. Nirmatrelvir ritonavir, it's oral, and it showed an 88% decrease in hospitalization and death at 28 days for patients that received this versus placebo in the EPIC-HR trial. Now, all of these targeted therapies act on the virus. And that means that they do best, they're optimized if we give them as soon as possible from onset of symptoms. Paxlevid needs to be given within 5 days of symptom onset. So the EUA is for treatment of mild to moderate disease, 12 years of age and older, 40 kilograms or more, and then a high risk of progression to severe COVID-19. So there's been a couple of trials now that have demonstrated that patients that don't have any risk factors really don't have statistically significant benefits from receiving those medicines. So again, something to think about, and has to be given within 5 days. The big challenge with Paxlevid is it's actually a combination of these two different protease inhibitors, nirmatrelvir and ritonavir. The ritonavir really just serves to boost the nirmatrelvir, but the challenge with ritonavir, as we've seen with patients living with HIV, is that it impacts this CYP3A metabolism in the liver. So any drug that's cleared through that is going to be impacted by this, and that's the big challenge with Paxlevid. Next slide. So for any patient that you're considering giving Paxlevid, you need to think about the other medications they're on. And if they're on other medicines that are cleared by CYP3A metabolism system, then you're going to have to look at whether those medicines need to be held, if they can be, or the Paxlevid dose needs to be adjusted. The pharmacist that's dispensing that's going to help some with that, but obviously it's good to check yourself as well to see if that's even an option for your patient. There's a real nice online resource, Liverpool COVID-19 drug interactions, that you can click, and it will give you even classes of medicines, and that's very helpful. But that's the big issue, and here's a list of the medicines here that you'll need to consider about. So things to think about, particularly I think of as danger medicines, antiarrhythmics, anti-epileptics are particularly of concern. And in the chat, you can see a nice COVID-19 drug interaction checker. Next slide. There are other drugs that if you give, may actually cause your Paxlevid level to go too low to be effective. And so that's what this list is showing you as well. So you can either have problems with the Paxlevid making the medicine that they're already taking have levels that are too high and can potentially cause toxicities, or they may be receiving some medicines like rifampin, which is used for treating TB, that may lower the Paxlevid to such a level that it's not even effective. So it's not a good choice. So again, checking medications for the patient is key if you're going to give anybody Paxlevid to see if you're going to run into any problems there. And I would just recommend using an online checker, drug checker for that, because there's a lot of different medicines. And it's important for people to list supplements too, because if they're taking an herbal supplement like St. John's wort, they need to be mentioning that because that could impact Paxlevid. Next slide. Other nirmatrelvir, ritonavir, aka Paxlevid issues. So the big one that you probably heard about, there's been a lot of this in the press, is Paxlevid Rebound, right? So what does this mean? So what we're talking about is rebound of both clinical symptoms, but also viremia. They do have an increase in their viral load again as well. And so this has been seen in clinical studies. It was actually a very small group, but as we've used more Paxlevid, we've seen more of this happen. So the exact number is unclear. I've seen a couple data points. One study was less than 1%, but another one was closer to 8%. So I think we're still not entirely clear how many patients, but it's a minority of patients can have a rebound in clinical symptoms and viremia. So important things to know with this is that the symptoms tend to be mild with recurrence. To date, we haven't seen somebody progress to a severe case, end up in the hospital with rebound. And so I think that shows that Paxlevid is still achieving its primary objective of preventing hospitalization or death. And so that's important. It is not recommended at this point that you restart another course of Paxlevid if somebody has rebounded symptoms. So that's really important. What they do need to do is re-isolate for another 5 days, because they are transmissible to other people when those symptoms come back. And I actually know of a case where somebody had stopped isolating with their household member, then they had rebounded symptoms, and then they did transmit to their household member. So that can happen. It's important for patients when you're giving them Paxlevid to let them know that in a minority of people, they may have rebounded symptoms, and if they do, they need to re-isolate for another 5 days. The other thing that, there's some other side effects. I think dysgeusia, or bad taste in the mouth. It's been termed Paxlevid mouth, is an issue that that's from the ritonavir component. We've seen that with our patients, people living with HIV that take ritonavir have had problems with this in the past. It can cause diarrhea. It can cause elevated AST and ALT. Next slide. So remdesivir is the second choice if the patient can't take Paxlevid. So we're familiar with remdesivir because we've been using this for a while now for our inpatients that have more severe disease. Very effective, it's well tolerated, but there is actually data from the Pine Tree trial that looked at this in patients that were not admitted to the hospital, outpatients, and they had an 87% reduction in hospitalizations and death at 28 days. So very, very close to the Paxlevid data. Really, I would say they're interchangeable as far as their efficacy data for what we have available. The challenge with remdesivir is IV. It's IV once a day, and you have to give it for 3 days. And so that's problematic, right, in the outpatient setting, trying to sort out how you're going to put an IV that's going to be either stay in for 3 days or be replaced each day for 3 days is the biggest challenge with giving remdesivir. It has a wider age range. You can use it from 28 days and older, so almost every age, which is great. And it doesn't have the drug-drug interaction issues that you have to worry about with Paxlevid. And so it's something to consider if you can't get a hold of Paxlevid or if it's contraindicated due to drug-drug interactions. And I think our best example of those patients that we've had to worry about this with are our solid organ transplant recipients. They're on several medications that they can't stop taking during their course of Paxlevid because of getting into trouble with their potential organ rejection. And so that's a patient population where we've used IV remdesivir, but with some challenges of giving that in the outpatient setting. That needs to be, again, administered as soon as possible, but within 7 days of symptom onset. Next slide. So monoclonal antibodies. So we've been using a lot of monoclonal antibodies, particularly at the beginning when we didn't have access to these other targeted therapies. So it's nice that we have those. The only one that we can currently use at this point is bebtelovimab. So sotrovimab, which was the one before bebtelovimab, there's been a succession of MABs, right? But bebtelovimab is the monoclonal antibody du jour that works against BA5, BA4. Although the data we have is not great. It's not the phase 3 trials data that we have for remdesivir or Paxlavid. And it's not as efficacious as those either. So that's why it's been moved to alternative status. It's for adults 18 years of age and older. Again, high risk of progression to severe COVID-19 and within 7 days of symptom onset. And so this is something you can use for your patients if you're not able to give them Paxlevid. It's still IV, so it's still something that you're going to have to keep in mind. Next slide. And then the last of our targeted therapies that we're going to talk about is molnupiravir. The trade name is Lagevrio. This has 30% efficacy in decreasing hospitalization and deaths at 28 days per the MOVE-OUT trial, and it has to be given within 5 days of symptoms. So the nice thing about molnupiravir is that it's oral, so you don't have to worry about an IV, but it has some challenges as well. It can only be given to patients that are 18 years of age and older that are at high risk, again, of progressing to severe COVID-19. But the issues are that there's animal data showing fetal toxicity. So the way this works, its mechanism of action is by mutagenesis, actually. And so there's concerns that the host cell can actually take up this medicine and cause mutagenesis. So it's not recommended in pregnancy. It also can cause bone and cartilage toxicity. And so it's not recommended, that's why it's not recommended less than age 18. So there are some challenges, something that you need to think about for your patient with considering molnupiravir. Where would you use this? I might consider it in a patient that I had that's not in childbearing age or able to conceive a child with somebody else. So that's something else to think about. So maybe my patients that are 65 and older, because we know that they're at higher risk, this might be something I would consider if I can't get an IV and they can't take Paxlevid potentially. But I'm just trying to think of examples of where you might consider this. So it's important to know about those side effects and warnings. Next slide. There are still ongoing studies, just mentioned briefly. Active 6, we've been participating at UT Health San Antonio. They're currently down to just looking at fluvoxamine, but they may be looking at some other medicines again soon. So we're continuing to get more information about outpatient therapies, which is great. So hopefully we'll continue to have better options for our patients in the outpatient setting, which is really where we're moving to treat most of our COVID at this point. Next slide. So importantly, what should patients not get for COVID-19? So NIH recommends against dexamethasone or other systemic glucocorticoids in patients that don't require admission to the hospital or oxygen. This is really important. We've seen a lot of outpatient glucocorticoid use, and so it's recommended that patients do not receive this. It may cause harm. There's been some data suggesting potential increased mortality rate in a large observational study of VA patients that didn't require oxygen. So important not to get dexamethasone for COVID-19 alone. Also, there's not data at this point to support hydroxychloroquine, antibiotics like azithromycin or doxycycline, and there are actually several well-done clinical trials right now that haven't shown benefit with ivermectin. And in fact, actually just on August 18th, there was another trial called COVID Out. There was a phase 3 study that showed that none of ivermectin, fluvoxamine, or metformin reduced hypoxemia, ER visits, hospitalization, or death versus placebo. So we're continuing to get good information about what we should not be using. We have some agents that are effective, and so we really should concentrate our use on how to use those most effectively at this point. Next slide. So here's a brief summary. That was a quick review of the targeted therapies, but nirmatrelvir, ritonavir, aka Paxlevid, all of these meds are as soon as possible from symptom onset, but it has to be within 5 days. Drug-drug interaction is really the key thing, and then remember, rebound is possible. Remdesivir requires IV administration for 3 days, so that can be tricky, but that's the second choice. And then the alternatives are bebtelovimab, our sole remaining monoclonal antibody at this point for treatment, requires an IV, and then molnupiravir, you have to watch out for it's oral, but you have to watch out. You can't use it in children because of bone and cartilage toxicity. Can't use it in people that are pregnant, and because of the potential for mutagenesis. Next slide. Oh, so don't forget there are good resources now. So covid.gov will take you to this slide, to this site. There's also the COVID-19 therapeutics locator that will show you where you can find these therapies and how much they have available with pharmacy phone numbers. Very helpful, important to have bookmarked on your computer. Next slide. And then references. So we mentioned having some references available. The NIH guidelines are great. They update those. The IDSA guidelines also very good. We have locally our STRAC guidelines, which our local ID physicians, ID pharmacists have contributed to, available in our area as well. So all three of these I would recommend as resources that are updated and are evidence-based and can be distributed and shared with others. Next slide. So last practice takeaways. Don't forget about vaccines. So we're going to talk about therapies, but obviously we want everybody to get vaccinated and be up to date. And don't forget about tixagevimab, sogavimab, trade name Evusheld for patients that are highly immunocompromised that aren't responding to vaccine. All patients with COVID need to be given instructions on how to avoid transmitting to others. You are able to have COVID in a household and not transmit it to other people. It's important to know about masking, isolation. And then last, currently nirmatrelvir, ritonavir is first choice and remdesivir is second choice alternative for our targeted therapies. Have really good data supporting them, are highly effective. So it's good, important to know how to use these and where you can find them. Next slide. I think that's it, and we're ready for cases.
Thank you so much. That was an excellent overview, very, very clear. We're going to go straight to a question put in the chat by Dr. Carlos Jaén, who would like to ask what risk factors are used to identify patients at high risk to choose them for the oral antivirals. How do you define high risk?
Right. So that's a good question. And if you look at the list in the CDC, it's a pretty comprehensive list, but it boils down to, we know age is the most important risk factor, particularly our patients that are 65 and older at highest risk of hospitalization and deaths. Chronic medical conditions. So really any organ system, if it's covered by a significant medical illness, but especially pulmonary, right? This is a respiratory infection, cardiovascular disease, are really high risk factors. Pregnant patients and immediate postpartum patients, they're at higher risk than non-pregnant. Our immunocompromised patients, whether it's from a primary immunodeficiency or from medications that they're receiving, are the top things I can think of categories I would consider high risk or listed. These are similar to the high risk categories we see for influenza as well.
So a follow-up question, if you don't mind. You know, a lot of our patients have elevated body mass index, and they may not have a whole lot else going on. But if you're contacted by somebody who is a relatively healthy person, maybe they're in their late 40s, early 50s, and really their only risk factor is an elevated body mass index. At the same time, they don't have any contraindications. And then something that's pretty typical for our demographics in this population around San Antonio is not everybody got fully boosted. So you have a patient like that. Are you going to say, hey, you don't have enough risk factors to get Paxlevid? Or would you consider that somebody who maybe didn't have the most robust vaccination schedule and is overweight might benefit?
And I think that I have to add, sorry, like we are in San Antonio, more of 60% of population or more, we are Hispanics. The majority of San Antonians, sadly, we are obese. So we can count that as two risk factors in a lot of people here.
I agree. Thank you for bringing obesity is definitely a risk factor. BMIs over 30 are a significant risk factor. That a BMI over 30 alone, I would consider a risk factor and would consider that person for therapy. If you get over 40, especially, they're at really increased risk for respiratory failure. And this holds true again for influenza as well. I know we're talking about COVID-19, but it really, in your mind, when you're seeing patients as we move into potentially influenza season as well, definitely a risk factor. Obesity alone, you start adding other race, ethnicity, other risk factors in there, and it really starts to bump it up.
Thank you. I see a question from Miguel Palacios. Where can we send patients for remdesivir if they're not candidates for Paxlovid? And perhaps Lindsay Groff, our PharmD, could take a stab at that one. Lindsay, where do we go?
Yeah, so I would work closely with your local health systems. We do at university have an opportunity to do home remdesivir, but there is a lot of coordination, as Dr. Bowling alluded to, about placing appropriate lines and having the pharmacy be able to compound that medication. So it is, again, a challenge. But we do have it as an option here at university, but does require a lot of coordination. There's very hit or miss on other health systems as to their availability of this product in the outpatient setting, unfortunately.
And so for outpatient docs who want to send a patient over to university for remdesivir, who do they call?
So right now it's still kind of a trial and error process. There's not 100% errored out, but it would likely talk to the ID providers and we can help get them triaged to the correct locations for the right people to get communicated with.
Does that sound reasonable, Dr. Bowling?
It does.
Ask the hospital operator for the infectious disease fellow on call.
Yes, and then we could help sort out, and if we can't sort out IV remdesivir, then look at what other alternative would best help that patient out so we can get it done in a timely way.
Okay, Rodrigo Najera is asking, how long after completing Paxlovid can we restart the statins? I'm going to go back to our PharmD with that one.
So great question. And as Dr. Bowling alluded to, there is a great resource with that drug interaction check that kind of talks through what that drug interaction is and how to approach it for a whole host of different medications, including statin. So with statin, the ritonavir can actually boost the statin concentration. So patients might complain of muscle pain or things related to having elevated statins. So depending on which statin it is, the recommendations are quite different. So since statins can be held for a short amount of time, often it's okay to hold it for that 5-day course of using Paxlevid concurrently and then restart it following that. But again, I would check the interaction checker for each particular statin to make sure there's nothing unique about the statin your patient might be using.
Okay, no one size fits all for the answer there. Beth Wickman, pardon my mispronunciation if it was. Any recommended intervals between the last or fourth booster and the new bivalent booster? That could be Dr. Bowling or Dr. Castro-Peña.
Jason. There is no recommendation at this time that we have clear, but if we go with the previous one, in between the third and fourth dose is going to be 4 months in between the 2 boosters. So I would think that it would be something pretty similar to this, but of course, this is gray zone. We are just taking it day by day. This can change every day.
I agree with that. And they should have some more information coming out soon when they announce when it's available to people to help with some of the timing there.
Okay, we're going to do one more question from the chat and then go to a case. Joaquin Muerte would like to ask, what are things we can tell our communities of color when they want to receive ivermectin and hydroxychloroquine because they are seeing more affluent communities use these? Dr. Castro-Peña.
This is going to be, you have to really sit down with these patients, or like sit down or by phone doing telehealth and explain them that really we have things are like really available and they really show that they can improve things. Ivermectin and hydroxychloroquine, they are like what people talk about that, but it is proof that actually they don't work and actually they can be harmful. So you really have to have a good communication with your patient. So you have to try hard and explain them and take your time with them.
Getting back to core principles of health literacy, right? Reestablishing the trust between the patient and the healthcare provider, actually taking the time to understand through active listening what the patient's concerns are, and then having a respectful tone and using clear language. Okay, I said I was going to go to the case, but Dr. Garcia, I can't ignore your hand is up. So you are on. What's your question, please? You're muted.
You're muted.
Any recommendations as far as after they get Omicron, is it safe to get the vaccine before 90 days, a booster, or is there any harm with that?
The question is, after you get infected with Omicron, is there a safe waiting period before which you should go and get boosted? I'm going to ask Dr. Bowling.
So yeah, great question. So there's not a safety issue per se, but the concern is that your patient may not get the best immune response if they get it right after they've had this infection. I, in general, have said maybe after about a month, consider then up to the 90 days. So you potentially have some partial immunity, but what we're seeing now with these Omicron subvariants is that partial immunity is not as good as it was with prior strains. And so, before it was 90 days, when the initial strain, people tended to have natural immunity that lasted for a longer time period, but it seems to be shortening. And so I've been suggesting maybe around 30 days as a recommendation. So you get to maybe back to baseline, they get the boost. It's not a safety issue to do it sooner than that. You just want to make sure they get as much response as possible.
Okay, thank you, Dr. Campbell.
Yes, thanks for the great summary, Greg. As far as outpatient steroids are concerned, would you recommend that people who have required steroids like asthmatics or need more steroids receive emergency evaluation rather than to try to increase or start steroids as an outpatient? That's quite a few individuals.
So we actually have a case that involves the steroid question. So I'd like to have Dr. Bowling and Dr. Castropena think about Dr. Campbell's question, but I want to move us to our first case where I think we'll place some context around this issue related to outpatient use of steroids and COVID-19. So Carly from the hub, could you kindly pull up the first case? And so here you see, folks, we have a nice new, easy to use red cap survey format case submission form. Then I beg you to send us your cases. We've made it painless. It's so easy. We'll ask you a little bit about who you are and what your credentials are, and then just give us the clinical case details without a whole lot of yada yada. It really takes 5 minutes to fill out, no mas. So here is a case that is from the real world that came to my attention. Somebody actually from the community called me up, and the issue was a person who has cough with Paxlevid Rebound. So this is a 65-year-old woman who is generally in good health and was diagnosed with COVID-19, treated with both Paxlevid and prednisone for 5 days. Her primary care doctor prescribed for her prednisone 20 milligrams daily to be taken together with the Paxlevid. And 4 days after completing the Paxlevid and prednisone, she awoke with a sore throat. She noticed robust sneezing, lots and lots of sneezing, and felt poorly, malaise. She also had a sensation of fullness in her sinuses. She tested positive for COVID, and this was after having actually tested negative around the time that she completed the therapy. So this was Paxlevid Rebound, and she reached out to her primary care doctor, who said that she should take hydroxychloroquine to treat her Paxlevid Rebound. She has no significant past medical history. Specifically, there's no history of reactive airways disease, no history of asthma, no history of any steroid-requiring condition, and she's actually not sure why that should say PCP, not her POP, why her PCP prescribed the prednisone with the Paxlevid, and she actually self-decreased the prednisone to half of the prescribed dose. She has no prior history of COVID-19. Please scroll down, Carly. Keep going. And she's certainly symptomatic. She had gotten 2 doses of vaccine, 1 booster, had not had the 4th at the time she got sick, wasn't pregnant, no medicines to complicate things. This is a well-educated professional who lives alone. She has a companion friend that she spends time with. That person has had 4 doses of vaccine and did not get symptoms. Her pertinent positives were cough, malaise, low-grade fever, sneezing, mild sore throat, and some subjective shortness of breath with this Paxlevid Rebound, but didn't have pulse ox in the house, and she's going to get a pulse oximeter now. Her pertinent negatives were no chest pain, nausea, vomiting, and certainly no severe shortness of breath. We don't have any additional data on her except there's no recent history documented of liver or kidney disease in this person, and her health literacy is very high. She has a graduate degree and she could do all of the things that we ask in this little form that we give you all. There were no language barriers. And my main concerns as related to this patient's understanding had to do with misinformation, the misinformation about the prednisone initially and then the hydroxychloroquine after that. There was a need to review isolation and quarantine protocols and what the differences are between isolation and quarantine, because there was ambiguity about that in talking to the patient, and just overall COVID-19 management. So I thought of a bunch of questions related to this case. And my first question is about this outpatient steroid use for people with COVID-19. How widespread is this practice? And is it harmful, Dr. Bowling?
So it seems to be fairly widespread. We've seen a lot of steroids in patients that don't require it for another reason and are not on oxygen. And it's not indicated. We've seen complications related to this as well. We've seen patients with diabetes develop DKA. As we know, there are a lot of side effects with the dexamethasone, the systemic glucocorticoids. Another concern you have with COVID-19 is that they may be doing okay with COVID-19 as an outpatient, but there's still a risk for potential follow-up superinfections with either bacteria or fungus, to include aspergillus. Putting patients on prednisone really increases their risk for fungal infections and bacterial infections, because you're addressing inflammation but suppressing the immune system. And if someone's not requiring oxygen, there's no benefit that's been shown in large studies. Recovery, there was a large observational study I think I mentioned briefly before for patients with COVID-19 that didn't require oxygen. Not only did they not have benefit, but they had an increased mortality rate. So we are seeing complications. It is not recommended to use steroids if a patient does not require oxygen with COVID-19.
And a corollary question, the Active 6 study that you've been participating in, at one point, I believe, had a budesonide inhaler as one of the arms. I see that that's dropped out. Was it taken out because it wasn't effective?
So that they're still working on the data from that, but overall, the data from this trials looking at inhaled nasal steroids has been mixed. And so we don't see a strong signal of benefit to where that's recommended at this point.
Okay. But no signal for harm that we know of either.
No signal for harm that I'm aware of either, no. Not for the inhaled.
All right. Now let's get at whether this woman merited therapy in the first place. She's vaccinated, but not fully boosted. Remember, it was 50 and up, should have gotten a fourth dose. She had gotten 3. She's 65. She has no other medical problems, really doesn't even have a body mass index issue. Would you have advised that she doesn't have enough risk factors to validate the use of Paxlevid here?
So I'll say, and I'll turn over to Dr. Castro. I'm interested in her opinion on this as well. I would still, 65 is a risk factor. We know that age is the strongest risk factor for complications. And so I definitely would use Paxlevid. It's generally, there's not a drug-drug interaction. It's pretty well tolerated. People can get past Paxlevid mouth pretty quickly. I'd be interested to hear Dr. Castro's take on it.
I have prescribed so much Paxlovid, and really, people get so happy with it. Of course, this is not reported everywhere. I'm telling you, I have seen, and patients really feel better way faster. I mean, talking about fever, I'm talking about the chills, in general, within 24 hours of starting it, a lot of them feel better. If I have somebody 65, no other risk factors, but there is no contraindication, I will do it. I will not have any, why not? In regards of that use of that prednisone, I don't know why the PCP did it, or the second recommendation for the rebound, the other medication. I think that her PCP has to be better informed, but in regard, Paxovid was a great decision, in my opinion. The other two options, in regards of the Paxlevid Rebound, I must say that, as Dr. Mergren was saying, that there is no recommendation for Paxlovid. There is one small trial that they are doing at the University of California to use it later on to avoid long COVID symptoms. But of course, the study is too small. So what is going to happen right now is that we have to wait for more data to come. But your question, Dr. Berggren, Paxlovid on the 65-year-old, yes, I will do it for sure. if the patient wants it, of course.
Okay, thank you very much. What I can tell you is this patient has re-isolated as instructed, did not go for the hydroxychloroquine, isn't feeling real well, has reached out to me and said, wow, I've really got a cough now, and I think I might be experiencing a little bit of shortness of breath. So I've urged her to get an actual thermometer and a pulse oximeter so that she can monitor herself more closely. I did ask her the appropriate questions about more complicated COVID-19 issues, like, do you have any chest pain, right? I'm thinking about DVT, pulmonary embolism, which has been seen. She doesn't have any chest pain. Her shortness of breath is really rather subjective. She's not vomiting, so she's not, losing the ability to keep herself well hydrated. And so we'll just follow, and based on the data that Dr. Bowling told us about, anticipate that she will not progress to where she needs urgent care or hospitalization. All right. I can't see the chat at this moment. I don't know. Somebody help me out. Were there questions related to this case in the chat? We missed the question from Beth Wickman about renal dosing with Paxlevid. Let's ask that.
So Dr. Groff responded in the chat.
And I will add, so it is dose reduced if the eGFR is between 30 and 60, and if the eGFR is less than 30, Paxlevid is actually not recommended. So keep that in mind as well as another reason why Paxlevid might not be the best choice for a patient with really poor renal function with the eGFR less than 30.
Okay. Well, thank you for that. I see the question about pregnancy, and the next case actually involves a lactating woman, and some of the questions we put in for this case may get at what Allison Winograd is asking us. So, Carly, could you kindly bring up the case, the next case that involves an infant and a mother? So this was submitted by our colleague in pediatrics, Dr. Nandini Mandlik, and she tells us of a 3-month-old male infant without symptoms of COVID whose mother is breastfeeding and currently has moderately symptomatic COVID-19. Mother was started on Paxlevid by her PCP on day 2 of illness after testing positive. She called the pediatric practice to find out if she can breastfeed while taking this medication, and she was told by her PCP to pump and dump. In other words, not stop lactating, keep using the breast pump, but to throw out the milk that she produced while she was taking the drug. She goes on to tell us that the infant has no significant past medical history. The mother didn't either, but was group B strep positive at delivery, had been treated adequately, and had good prenatal care. There was no prior history of COVID. The child doesn't have COVID symptoms. The child is not vaccinated. And so this is a pediatrician filling this out. She took the child's point of view. Social history is lives at home with mother, father, 2 siblings, no social stresses, uses WIC services. Other pertinent positives are that the mother has had upper respiratory symptoms, fever, headache, and fatigue, starting to feel better now on day 3 of Paxovid, just like Dr. Castropeño told us we should expect. No change in her breast milk production, but she has been pumping every 3 to 4 hours. The infant is asymptomatic and has already been switched over to formula, and the formula is being tolerated well, but the child is slightly more fussy than usual. Exam is benign. We have a COVID positive mom with normal labs at 6-week postpartum visit. This is a Spanish-speaking mother. Father is Spanish-speaking as well. Dr. Mandlik attempted to engage the mother in shared decision-making, but she preferred to follow my directions instead, despite my attempts to balance the power differential. The person's health literacy was that they could determine what time a person can take a prescribed medication, but they couldn't go beyond that to calculate the cost of their health insurance. And so the questions are, number 1, is Paxlevid safe for breastfeeding mothers and infants? Let's go to our PharmD, Dr. Lindsay Groff, for that.
Yeah, thanks for sending it over here. So right now there's really kind of limited data in the pregnancy and lactation area, especially in the pregnancy area. Ritonavir can, which is one of the components of Paxlevid, get into the breast milk. And this medication has been used for years in people living with HIV, and there is data to show that it is safe in the people living with HIV population. And it's thought that also the other component of Paxlevid would be okay in lactation if the baby is otherwise healthy. So again, it is a risk-benefit discussion, as with a lot of medications in lactation, but there is no major contraindication in using Paxlevid in a lactating mother, and shouldn't have to pump and dump if other considerations are taken into account and agreed upon with the provider and the patient.
Dr. Bowling, I see you nodding. Did you want to add to that?
I would agree. And NIH clearly states that you should not withhold Paxlevid from a woman that is breastfeeding or pregnant.
And are lactating women at higher risk for progression to severe COVID? And is that maybe a reason to encourage a breastfeeding mom to go ahead and take the Paxovid?
Lactation as itself, I'm not aware of that being a risk factor, but being that post-pregnancy, postpartum time period appears to be a risk factor for all the way up to at least 42 weeks, which is longer than what we've seen with flu. Influenza, there's a postpartum period was just immediate, 2 weeks following delivery. But for COVID, there seems to be a longer time period of increased risk compared to a woman that hasn't delivered. So 6 weeks after.
So Dr. Castro-Pena, how would you have talked to this mom?
I will literally tell her, like, of course, whatever she thinks that is okay for her, but I would really encourage her, if she's at high risk, to get the Paxlovid. There is no contraindication. She will not have to pump and dump. There is no reason for it, and continue breastfeeding her baby. That's something that really is going to help that baby that highly likely is going to get the COVID as well.
So I've also read that the nirmatrelvir is a rather large molecule. We don't have any data, but we don't think very much of it gets into breast milk. We know that a small amount of ritonavir does, but you need a lot of ritonavir there in order to make the nirmatrelvir fully available. So even if the baby is getting a little nirmatrelvir, they're probably getting such a tiny amount of ritonavir as to make the nirmatrelvir almost irrelevant, not really bioavailable. Okay, so I think that we will gather more data about this prospectively, of course, and be smarter about this next year than we are now. But we have enough information to encourage breastfeeding mothers that Paxovid is okay for them to take, and they can keep on breastfeeding their babies. We do have a few more minutes. Does the audience have questions about this case? Would they like further clarifications? And what about pregnancy? I guess we didn't really address that when we talked about it. Allison Winograd asked, are there any therapies that have been tested and safe in pregnancy? She saw that either Paxlevid or monoclonal antibody can be used, but haven't been able to find any data on the safety. Let's start with Dr. Bowling and go to Dr. Groff after that.
Yeah, that's a great question. So I would say in general, as it is with most medicines, we have very, very limited data for our pregnant women or immediate postpartum because they're not usually included in clinical trials. But we do have a wealth of data for use of ritonavir, as was mentioned, when we're talking about breastfeeding in pregnancy for our patients that are living with HIV, and it's well tolerated. Animal data suggests that nirmatrelvir and ritonavir are safe in pregnancy as well. And so I would still choose Paxlevid as a first choice for a pregnant woman that I was worried about that she needed to be treated. And then remdesivir also doesn't have clinical data, but there's actually some pregnancy registry data, including out of Texas, which showed that pregnant women compared to women that weren't pregnant had similar outcomes. Or pregnant women that received remdesivir versus pregnant women that didn't receive remdesivir. There was no change in neonatal or pregnancy outcomes based on that. So it appears safe. It's very well tolerated, actually. So I would have no problem giving a pregnant woman, if they're appropriate to receive that medicine, either Paxlevid or remdesivir as a second choice.
Okay.
Yeah, and I was just going to quickly remind, with molnupiravir, there is data that shows that it is harmful in pregnancy, so that agent should be off the table if a patient is pregnant. While Dr. Bowling shared the other data, it's probably okay for the first two preferred options.
Okay, excellent. Thank you very much. So Dr. Garcia brought up a question in the chat. Dr. Bowling answered it, but I'd like to make it salient because it was part of the third case, which I think we're going to skip now because we're heading into the end of the hour. But the question is if we treat people who have mild or moderate outpatient COVID, can we realistically argue in favor of the treatment because we believe that treating it may reduce their risk of long COVID? Certainly is an appealing argument, but are there any data to back that up? Dr. Bowling?
Yeah, it's a great question, and we need more information on this, right? There's some ongoing studies about long COVID, and UT Health San Antonio is participating in some of those. There's data that indicates that people that are vaccinated are less likely to have these longer term symptoms following COVID-19. And so along those lines, it's thought that if you can blunt the severity of the disease with these targeted therapies that we're talking about, you may also have some impact there as well. That part's not as clear. And so we need more information. These large studies that are being done now, huge cohorts of people with long COVID symptoms hopefully will help us answer that a bit better. But I'm hopeful that it's an additional benefit for treating our high-risk patients, is that not only are you preventing them from getting severe disease, but maybe you're blunting their risk of longer-term symptoms. But that we need more data at this point, is my understanding of the data that's available.
Excellent. Trying to catch another ball here. Rodrigo Najera, should Paxlovid dose be adjusted during pregnancy? Lindsay Groff?
There's not any specific dosing changes in pregnancy at this time in regards, because it comes as a blistered pack, so we're kind of limited on the dose adjustments, but nothing that I'm aware of to date for pregnancy.
Okay, and Mia Vento put in a question on behalf of Beth W. What is your cutoff regarding results of pulse oximetry results for more aggressive treatment? We'll ask Dr. Bowling and we'll ask Dr. Castro-Pena. What's your cutoff regarding results of pulse ox for more aggressive treatment?
90%. I use 90% as my threshold. Of course, you have to check the patient baseline, but 90% or less, I send to the ER immediately.
Dr. Bowling?
Yeah, so I guess I would say it partly also depends on the patient's baseline and then what other symptoms they're having as well, right? So if it was 94%, but they were feeling confused or having shortness of breath at rest, I would send them then. So I think anywhere in that range. When you get below 95% is when you start getting worried, and then you're going to need more close follow-ups. It also depends on their access to pulse oximeter. And then the other thing to mention is that we have learned that people of color, pulse oximeters may not be quite as effective as in people with lighter skin. And so it's a little bit tricky with that. So definitely, I agree with Dr. Castro, less than 90, you need to go in. But above that, I would take into account their symptoms, their ability to check pulse ox on a regular basis moving forward to see if they need to be further evaluated.
Yeah, I guess I've had a few patients that will tell me they periodically dip down to 93, and then they get a little anxious because I've used the 94 cutoff. But then on further talking to them, I ask them to make sure that the battery is good, that they're using the pulse ox properly, is this really a change? And are they staying down there? And sometimes people dip down, but then after you have them relax and take a few deep breaths and try again, then it kind of comes back up. So I think it's really good to have a combination of the number and the clinical context and the symptoms that the patient's experiencing, and not to forget about being more likely to refer if it's a patient of color where you're not sure you're getting the accurate pulse ox reading. Better to err on the side of making sure that person gets properly evaluated. We've had some bad outcomes, unfortunately, for people of color. One more question from Allison Winograd. Is there any safety data on the same patient taking both Paxlevid and monoclonal antibody therapies? Dr. Bowling.
I'm not aware of any safety concerns. I don't know if you could give both. Paxlevid is just much better. The data supporting Paxlevid, the data supporting the monoclonal antibodies, frankly, has not been great from the beginning, but it's what we had available. Now that we have better therapies available, I mean, there are risks with getting monoclonals. People can have infusion reactions. They have to be monitored for 30 minutes to an hour after receiving. So if someone could take Paxlevid, I would just give them Paxlevid. I don't know that there's any data supporting benefit of giving the infusion. There's been a kind of a national supply issue with the monoclonals as well. So I would just give the Paxlevid alone. Not out of concern that there's a safety issue, but just efficacy standpoint.
So last point that I'd like to have everybody share. I was made aware of a patient who called their PCP. This was up in Dallas. This family practitioner in Dallas told the patient that he does not treat with Paxovid. And the patient was not given any alternatives, and the discussion was not based on the patient's risk factor, her age, or her vaccination status. It was, this doctor doesn't do that drug. what recourse would she have, Lindsay Groff? Does one have to have an MD to prescribe Paxlovid?
Yeah, great question. So the EUA was actually updated to allow tests to treat. So pharmacists can actually prescribe if they have the appropriate data and information. So that includes health data, med lists, and things like that, which are laid out in the EUA. But long story short, there are pharmacists that can prescribe some of these targeted therapies that have been shared today. So patients can use those as another approach to getting into healthcare system and getting therapies they need in a timely manner.
And that seems like a really good piece of information for all of us to have, whether we're a community health worker, an MA, an LVN, or any role that we play within the healthcare team, knowing that patients can gain access to Paxlovid, which can save lives and keep people out of the hospital, and that this access does not require an MD, but rather a trained PharmD who knows how to screen for drug interactions as well as liver or kidney problems that can help people get better access to this drug. Excellent. Well, I think we're up against the hour, and I want to thank everybody, our panelists, Dr. Bowling, for an outstanding review. And I'd like to turn this over to our hub team now.
Thank you. Thank you very much, Dr. Berger. This has been a wonderful opportunity, and it's a wonderful information. There is also, it was a question in regards to the CME, and the information is in the chat. There is 2 steps to follow to have this continuing education. There is the information in the chat. Also, I would like to invite you to consider to present a case, clinical and not clinical, and follow up for those cases that have been presented. There's going to be a wonderful opportunity to learn together through these sessions. And again, thank you to our panelists, to our presentations, and thank you all to be with us today. Our next session is going to be, please mark your calendar, it's going to be Friday. Okay, this wasn't a special occasion just for today, but it's going to be Friday, September the 16th at noon. You have a wonderful rest of the day. Thank you so much for being with us.
And the presenter is Dr. Barbara Taylor, is that right? For our next session?
Yes.
I believe I saw that flyer go by. She'll be updating us on vaccines. There's been a lot of developments there with pediatric vaccines and then the EUA for the Novavax and some nuances about what kind of patient should preferentially get which type of vaccine. So that'll be very interesting for all of us. And we look forward to seeing you there. Remember that if you attend a lot of our sessions, you'll get a lapel pin, a Health Confianza lapel pin with our logo on it. And for the very high attendees who fill out our survey forms and submit a case, there's a lot of swag for you, including a certificate celebrating you as a health literacy champion of Health Confianza. Thank you very much, everyone, and we look forward to seeing you at our next ECHO session.